Yes, thanks for the introduction. So we know the stroke is the leading cause of death worldwide, and ischemic stroke is a major type of stroke. And we know the intracoronary atherosclerotic disease is a major cause of ischemic stroke worldwide, especially in China. And also we know the recurrence rate after first-time stroke is actually very high, and data shows from 10% to 50%. And that means the standard medical therapy sometimes can fail. And actually, it's, if you are a neuroradiologist, you may see these patients have recurrent TIA and strokes, and you can't do anything about them. So now the research community has lots of attempts to improve this. And there is a famous SMRA trial to show the intracoronal stenting is not superior to medical therapy, so it's not recommended. However, just several months ago, there is a WAVE trial recently shows the intracoronal stenting has favorable outcome compared to medical therapy only in the patients who already failed medical therapy. So that means if we can identify these patients, maybe benefit from more aggressive treatment, maybe higher dose of the medication or a more aggressive intervention, so we may identify this patient earlier and prevent future stroke. So the high resolution MRI, black blood vessel wall imaging can identify some vessel wall plaque features, and some previous studies to show these features are associated with acute stroke. However, most of these studies are cross-sectional studies. There are very, very few longitudinal studies, and there are very little data on how the plaque change over time. So the aims of this study, first, to investigate the prognostic value of vessel wall imaging for recurrent stroke, and second, to evaluate the temporal change over time of these plaque features and how they related to recurrent events. So this is a prospective study with inclusion and exclusion criteria listed here. And we only include patients in acute phase to have a homogeneous population. And the patients have undergone vessel wall imaging at the baseline, then a closer follow-up between 3 months and 1 year. We also collect the patient clinical information. This is a scanning parameter, is a two-dimensional multi-contrast MRI. And the images are analysis by 2 radiologists, and each detected plaque was independently classified as a carotid plaque if it is in the stroke trajectory, and this, if multiple stenosis are there, we classify the most stenotic plaque as a carotid plaque. For image analysis, we segment using a SMRA2 software. We measure the stenosis, lumen area, plaque burden, which is a percentage of plaque area at the most stenotic location, and contrast enhancement percentage and the remodeling index. We also identify the intraplaque hemorrhage as identified by more than 1.5 times signal of the nearby muscles. We use survival analysis and Cox regression to see the factors related to recurrent events. And this is the result of the flow chart. We, from about 100 patients, we have 41 patients with intracoronary atherosclerotic disease. We collect the patient clinical information, blood biomarkers, and also have 2 MRI examinations with a 3 to 12 months interval. On average, is 6 months. And then we follow the patient clinically for maximum 4 years to monitor their recurrent TIA or stroke by telephone interview and sometimes their clinical visit. And this is demographic and clinical characters of these patients. In a total of 41 patients, there are 7 of them have a recurrent ischemic events in the same stroke territory. And then we found there is no big difference shown on the right for the recurrent group, 7 of them, and the non-recurrent group, there is normally no big difference, except the lipid levels. And for the plaque characters, we found for the enhancement ratio, as shown here, at the baseline, they are quite similar, about 40% enhancement. During the follow-up MRI, the recurrent group have a consistently high enhancement ratio, while for the non-recurrent group, the enhancement ratio significantly dropped. Although the statistic doesn't show significance, the trend is quite obvious. Then we found the progression of plaque burden is much more prevalent in the recurrence group. By doing this Cox regression and multivariable analysis, we found only these lipid levels and progression plaque burden is independent predictors of recurrent stroke. And here is the survival curves. As shown, the blue line is the patient without progression of plaque burden, and the red line is patient with progression of plaque burden. We found significantly more survivals in the non-progression group. And the reproducibility of this measurement are very good. And the measurement error for plaque burden is quite small, only 5%. And other measurements have a range of 5% to 18%, which is considered acceptable. Here I show some cases. Here is the patient at baseline shown on the top. You can see there is a stenosis in the basilar artery. The basilar artery. And this is multi-contrast MRI. And after 1 year, the patients, we see the stenosis actually is less. Also, it's shown on the black blood MRI, and this patient is stable without recurrent events. It improves. And this is another patient. We can see the stenosis is become a little bit worse. And when you see the vessel wall imaging, it sees from maybe a moderate degree of stenosis progression to nearly occluded. So this patient have a recurrent stroke. So in summary, we found the progression plaque burden predicts future stroke. And the enhancement ratio drops in stable patients but keeps high in the recurrent stroke patients. And monitoring this patient with repeated vessel wall MRI may provide additional value. However, we have some limitations. The sample size is small. We didn't use a 3D MRI, and no imaging confirmation for recurrence events like DWI. It's also a single center study. So in conclusion, we found the progression of plaque burden identified by repeated vessel wall MRI predicts future TIA or stroke. Thank you for your attention.